Aruna Vijayasinghe, consultant cardiologist at Base Hospital, Panadura. He'll be giving a talk on supporting the circulation, and this will be an in-person physical lecture.
Hello, good morning everybody. I am Dr. Aruna, consultant cardiologist from Panadura Base Hospital. Today I am going to discuss about circulatory support in critically ill cardiac patients. The objective of this discussion will be to understand who are critically ill cardiac patients and causes for circulatory failure, and a little bit of pathophysiology of circulatory failure, and finally how we are going to manage it basically with the available supports in Sri Lanka. There is no universal definition for critically ill cardiac patients, but in day-to-day setups, most of the patients with acute heart failure, irrespective of cause, can be considered as critically ill patients. The extreme end is the cardiogenic shock, where patient need circulatory support to maintain their blood pressure. So in this discussion, I will mainly focus on patients with cardiogenic shock. Cardiogenic shock is defined as the systolic blood pressure less than 90, and our patient need inotropes or vasopressors to achieve blood pressure more than 90. So simply, any patient who is on inotropes can be considered as a patient with a cardiogenic shock. However, apart from this blood pressure criteria, they need the clinical signs such as cold extremities, oliguria, confusion or narrow pulse pressure, and laboratory evidence such as acidosis, elevated lactate or rise in creatinine as a supportive evidence for diagnosis. Why it is important? If we take a patient who come with a STEMI to our ward, the mortality is around 5 to 10% if they don't have cardiogenic shock. Unfortunately, if the patients develop cardiogenic shock, the mortality increases significantly, and usually a patient with well-established cardiogenic shock is around 50%. So you can see with the development of cardiogenic shock, mortality rises dramatically. So early recognition and early treatment is the key for the patients with cardiogenic shock. When it comes to pathophysiology of circulatory failure, whatever the cause, it can be a ischemic heart disease such as STEMI or non-STEMI, it can be a hypertensive emergencies, or it can be arrhythmia or valvular disease or myocarditis. There is an ongoing myocardial injury, and it causes systolic dysfunction as well as diastolic dysfunction. At the same time, this ongoing damage causes release of lot of inflammatory mediators. So basically the damage occurs due to the systolic and diastolic dysfunction and inflammatory mediators. With the systolic dysfunction, heart can't pump blood into the circulation, so stroke volume and the cardiac output will drop, and as a result blood pressure will be low. And with the diastolic dysfunction, the LED left ventricular, there's blood remains, and it causes pulmonary congestion, and patient develops significant shortness of breath and causing hypoxia. So ultimately, both systolic and diastolic dysfunction causes hypoxia to the heart as well as other organs. So this is basically a vicious cycle. Then this hypoxia causes further ongoing damages and releasing more and more inflammatory markers, causing more vasoconstriction. So when you come to the management, the most important thing in management is to identify these patients early and give the support and prevent them going into cardiogenic shock. So in practice, imagine when the patients come with a STEMI or hypertensive emergency, most of the time we keep them fasting for hours or sometimes even days. Most of the time we keep STEMI patients fasting for 24 hours. But ideally this is a bad thing because it causes dehydration and it was the ischemia. So if the patient is stable, there's no ongoing pain here, they don't need intubation and there's no vomiting, we have to start oral feed in early stages. In addition, early management of the underlying cause such as reperfusion, PCI, controlling heart rate will be helpful to prevent patients going into established cardiac failure. the aim of our management, the most important thing is in the setup, we understand the pathophysiology. So what we have to do now? So we have to increase the contractility of the heart. That is the power of contraction. So by increasing contractility, we can increase the stroke volume, the cardiac output, and finally we can achieve our target blood pressure. That's the main aim of circulatory support. In addition, depending on the peripheral circulation states, we might have to go for vasoconstrictors or vasodilatation. If there is a significant vasoconstriction, we might use vasodilatations, but most of the time we prefer vasoconstrictions because with the vasoconstriction, it increases the peripheral resistance and we can increase the blood pressure. In addition, we have to pay attention to control the heart rate because depending on the heart rate, diastolic filling changes. So in the higher heart rate, the diastolic filling is poor, so stroke volume will be invariably low. So we have to maintain the patient's heart rate at the favorable range. So definitely this kind of management, it's better to get support from our anesthetic and critical care colleagues, because when we involve more people, they can give better ideas. So our therapeutic goal of this situation is to restore the organ perfusion and weaning off vasoactive drugs regularly, and in the same time, parallelly, we have to plan for intervention. And so the previous presenter talked about the respiratory support, and this stage we mainly focus on the cardiac support. So we have to, in the main assessment of the patients, we have to look for blood pressure, pulse rate, lungs for bibasal crepitations, cardiac heart auscultations, look for acute murmurs such as MR, acute mitral regurgitation or VSD. The basic blood investigations such as blood gas to look for acidosis and lactate, increased level lactate, routine blood such as creatinine, AST/ALT to look for acute renal and liver injury. And echo will be very important to diagnose the left ventricular failure. In addition, it gives idea about acute MR, VSDs, pericardial effusions, even pulmonary embolisms, so other rare causes of cardiogenic shock. When you come to the guidelines, I would like to highlight two things in this guideline. The third sentence, it's in patients with cardiogenic with complicating acute coronary syndrome, and immediate coronary angiography is recommended within 2 hours from hospital admission with an intent to perform coronary vascularization. This is not very practical in Sri Lanka, but this we have to remember in our mind that all patients have cardiogenic shock and following STEMI or non-STEMI, they need early angiography. So if you can push the cardiology unit to get an angiogram, that would be the best thing. The thing I want to highlight is a fluid challenge. Saline or ringer lactate more than 200 ml over 15 to 30 minutes is recommended as a first line of treatment if there is no signs of fluid overload. So always we have to give a fluid bolus and see, provided their lungs are okay and there is no significant peripheral edema. Because most of the time these patients are dehydrated, and fluid challenge will help to improve their blood pressure. So we must have a basic idea of ionotropes and vasopressors at this stage, and most of these ionotropes and vasopressors act on these basic receptors, alpha-1, beta-1 and beta-2 receptors. These are the commonly used ionotropes in our setups. Noradrenaline is a drug of choice. It has enough evidence to use as a first drug in cardiogenic shock. It's basically act via very potent alpha-1, that is a vasoconstriction. Beta-1, it's basically increased contractility and heart rate, and it's very little beta-2, that's vasodilatation. The second drug we commonly use is dobutamine. Again, beta-1, it has a predominant inotropic activity and vasodilatation. And dopamine, at low doses it acts via dopamine receptors, but at high doses it acts via both alpha and beta receptors. So basically it increases the vasoconstriction and contractility. Adrenaline has a very potent beta-1 and alpha-1 activity, so it's increased inotropic activity as well as vasoconstrictors. Vasopressin basically acts via vasopressin receptors, and milrinone acts via phosphodiesterase inhibitor. These are less commonly used ionotropes, and milrinone is especially useful in a setup with RV failure where we want to reduce the pulmonary hypertension. But it is a less commonly used drugs compared to first 4 drugs. So this is the very important thing, practical point, when you are administrating inotropes or vasoconstrictor, the venous access. Ideally, we need a central line, but most of the ETU setups, HDUs and wards, we can't get a central line. So it's better to have a larger vein, more than 5 millimeter vein. It can use an external jugular or vein at anterior cubical fossa or the arm. The veins at forearm and dorsal aspect of the hands are best avoided because these are small veins and we can't give a proper dose, and most of the time the response is not adequate. The other most important thing you have to remember is noradrenaline dose. In Sri Lanka, noradrenaline, it says 2 ml contain 4 milligram of noradrenaline, and most of the time calculations depend on those. But ideally, you just remember this, even though it contains 4 milligrams of noradrenaline by tartrate, the equivalent dose of noradrenaline is 2 ml. So 1 ml noradrenaline contain only 1 milligram of noradrenaline. 2 ml noradrenaline contain 2 milligrams. So this is a practical point, remember, in your wards when you are preparing noradrenaline infusions. I'll briefly tell about mechanical circulatory devices. These are not available. There are several devices: Impella, Tandem Heart, ECMO and IABP. IABP is available in few cardiology centers and ECMO is available in Karapiti. But remember, these are not very basically they increase the peak pressure and lower the diastolic pressure. So basically it improves the organ perfusion and coronary perfusion. However, the important thing to remember is this: even though IABP looks fascinating, it has not improved the mortality or 1 year or even up to 6 years. So just because we don't have IABP in our most of the wards, we don't have to be discouraged. It's not very useful and just we can forget about it. Apart from circulatory management, we have to focus on other things as well. DVT prevention. All patients must be on DVT prophylaxis, remember, and subcutaneous enoxaparin 40 milligram daily, and it's better than DVT stockings. So summary, cardiogenic shock is relatively common and its early prevention is the important thing. We have inotropes, vasopressors and diuretics. Some centers have intra-aortic balloon pumps. But whenever you use inotropes and vasopressors, remember large veins, anterior cubital fossa or above, or neck veins. And when you are calculating noradrenaline, the most commonly used drugs for cardiogenic shock, remember 1 ml contain only 1 milligram of noradrenaline, not 2. So this causes a lot of confusion and underdosage. Thank you very much.
Thank you very much, Aruna, for that very comprehensive talk on supporting the circulation. Before we go on, may I just remind our virtual audience, as Dr. Sandamali mentioned before as well, if you have any questions to ask from our lecturers for these symposiums, please use the Q&A button in the Zoom link. You can log in individually as well if you wish to ask questions, and type the questions and it will appear in front of us, and then we can, at the end of the symposium, pose the questions to the lecturers as well. To carry on, let me allow Dr. Sandamali to introduce our next lecturer.
And also, may I remind that even the physical people who are at the physical meeting, if you just write the question on a piece of paper and hand over to our coordinator, he will type the question for you. Okay, our next speaker